Now remember, these three are the important serologies that you want whenever you're screening for patients, because that tells us what this patient might have. So the question for the group, again, is now what? Does this patient have hepatitis B? Does this patient have, what do we do next? Right? So if everyone had their mics on, we could actually have a interesting conversation about this. But for the interest of time, I think, again, to go back into Serologies 101, step one is basically to look at those three serologic markers, okay? So if a patient has surface antigen that is positive for more than 6 months, that is a marker for chronic hepatitis B. You don't need anything else, okay? So hopefully this patient was recently diagnosed with surface antigen positivity. So we got to assume that she probably may have had surface antigen positive for the time period of 6 months, because she comes from an endemic area. Again, if you want to further assess whether she has chronic hepatitis B or not, you're looking at the serologies, which one of them is hepatitis B core antibody. And core antibody tells us that the patient has been indeed previously exposed, okay? Hepatitis B surface antibody is a marker for immunity to hepatitis B, and she doesn't have that. So we're thinking that this patient definitely has surface antigen that is positive. So in this case, we go to the next step, which is listed on the PowerPoint. We check for E antigen, E antibody, and DNA. Now, out of all these three, DNA tells us about whether the hepatitis B is actively multiplying or replicating, or whether the patient has just a carrier state. So E antigen and E antibody, again, if you go back to our prior module, we've talked about envelope antigen being a marker for very high infectivity or very high viral replication. So we do that to identify if this patient has a wild type virus, or if the patient has E antigen negative disease, then we're thinking of a pre-core or basal core promoter mutation, in which case, if you're thinking of starting treatment, you will actually start treating at a much lower levels. Okay, so I think at this time, I would want to kind of pause for a little bit and see if anyone in the audience wants to share any clinical cases that they want to present. Typically, the way ECHO projects work is we talk about all the cases that you have in your, that you see in your clinics. If you have any questions, if you have any concerns about when to start or when to refer a patient or how to assess the patient further, we discuss about those topics. So I'm just gonna pause for 30 seconds to see if there are any volunteers who want to share their information with us.
Yep. And at this juncture, please feel free to unmute yourself if you would like to contribute to the conversation, or if you can't, please put it in the chat. Thank you.
Okay, so Alex basically wrote in the group chat that we would check for the transaminases, correct? We would check for the envelope antigen, envelope antibody, and for the DNA. Absolutely, okay? And he also wrote we should also check for an ultrasound. Now, again, if you take back the information that was already presented, ultrasound in this kind of patient is important because although these patients are chronic hepatitis B, and although they don't have cirrhosis, they can still be at risk for liver cancer. So ultrasound is a recommended screening test to look for liver cancer. So if you guys do not have any questions or any clinical cases to share, I actually pulled out 2 of my cases from yesterday. And without identifying patients' names and other things, I want to kind of share these cases with you to see where you all stand. So this is a 63-year-old woman who actually is a nurse in one of the local hospitals. She was diagnosed with chronic hepatitis B about 4 years ago. She denies having any prior episodes of jaundice or liver decompensation. But what she noticed was when she first presented, her creatinine was up, and she was seeing a primary and a nephrologist, and she was diagnosed with IgA nephropathy. Currently, she has a creatinine of about 2.3, and she's a woman from Philippines. So her BMI is about 28, but she's a little short for her height. And the GFR is about 24. She denies any family history of hepatitis B that she can recall. She also denies any family history of liver cancer or unknown liver diseases. During the workup, she was told that her ALT was about 100, and she did have hepatitis B surface antigen. She was getting evaluated for a kidney transplantation. However, until now, this has been almost 4 years, that her GFR has remained about 24, and she's continuing to urinate. She's urinating about 700 ml to a liter every day. She denies any other symptoms. She denies jaundice. She denies pruritus. So obviously, when you want to look at her past medical record, she did have hypertension. She did have the IgA nephropathy. She's a little bit overweight. BMI is 28. Past surgical history, appendectomy in 2018. She had a gallbladder removal in 97. She's on losartan, nifedipine, and vitamin D. Family history, she didn't have any family history other than father who had rectal cancer. Sister had hypertension. Brother died of a sarcoma, and another brother had hypertension. But again, there is no hepatitis B or liver cancer. She doesn't smoke. She doesn't drink alcohol, and she works as a nurse. She's married, and she has 2 kids, and the kids don't have hepatitis B as well. Review of symptoms, except for mildly decreased urine output and few arthritis-related issues for a 63-year-old woman, nothing major. Her labs, again, like I said, platelets are about 208. Her ALT is about 34. It ranges between 34 to 104, and creatinine is 2.3. Now, so far, she hasn't been treated for hepatitis B at this time. Her ultrasound showed that she had hepatic steatosis, and she has a renal cyst. She also comes with a FibroScan that was done by her primary care. And the FibroScan reading was 3.9 kilopascals. Okay, so for those of you who do FibroScans, 3.9 or any value less than 7.5 kilopascals is normal. So her primary care was basically debating whether to treat this patient or not. And from a renal standpoint, obviously the patient was stable, and she was referred to me for further assessment. So again, looking at her, she's an older woman, but the points are she does have surface antigen. She's E antigen negative. So at this time, we didn't have any hepatitis B DNA. So I checked for hepatitis B DNA. And the results, the DNA is about 1,900 international units. But again, the ALT is elevated. So we're worried about what could be the cause for this elevated ALT. If you look at the FibroScan is normal, right? So in this kind of a patient, would you start the patient on antiviral therapy, or would you start this patient on, or would you rule out other causes? And if you want to start an antiviral therapy, what would you choose? And how frequently do you dose the antiviral therapy? So these are pertinent questions, right? So if anyone in the group wants to volunteer, we can definitely have a conversation about this patient.
Does anybody have any questions about the patient or the case that Dr. Bhamidimarri just shared?
Do you want to know more information about any of the other tests? So again, in the interest of time, for this patient, again, the elevated ALT, but the patient does have low viral load. So again, to think about starting to treat for hepatitis B, we want a hepatitis B DNA, especially in an e antigen negative scenario. The ASLD recommendations will be at least to follow these patients and treat if the hepatitis B DNA is more than 2,000 international units. So other concomitant factors that this patient can have is the presence of NASH. Okay, we do see that on the FibroScan, she had a CAP, which is the attenuation parameter, of about 365. She has a BMI of 28. She does have mildly elevated LDL and low HDL. So again, she has hyperlipidemia. She's not on any statins. So again, it does increase your threshold, whether this is hepatitis B or whether NASH is also playing a component. So these are some of the things that you want to think about even when your patient just has chronic hepatitis B, but think about the other causes that can elevate the liver enzymes. Sometimes you need to counsel patients if they are drinking alcohol, because adding alcohol, adding fat, adding other concomitant liver injury can actually make their disease progress faster. So in this patient, we actually opted to do a liver biopsy because we want to make sure that we want to assess for NASH, we want to assess for hepatitis B chronicity, and although the FibroScan is normal, we want to assess for fibrosis in this patient. But again, she doesn't have stigmata of portal hypertension. She doesn't have stigmata of cirrhosis. Okay. Now, hepatitis B treatment, we're going to discuss if we're going to treat this patient, because I will come back to this scenario when we're in the next module, when we talk about treatments. Everyone kind of agree with this? Anyone wants to add? Dr. Alex from Brazil, would you do anything differently? Okay, so Dr. Alex agrees with me, and again, please feel free to write your opinions, and also, share if you want to know more about the patient. If you have similar patients, what to do. Okay, and he also made a comment that it is discordant that ALT is elevated and hepatitis B is low, which is actually true, and that's what should raise the suspicion in anyone who is treating these individuals, that although the patient has chronic hepatitis B, it may not always be hepatitis B. We need to basically look for other causes, and we need to counsel these patients. Okay? Yes. So we do have a suggestion from him to discuss about a case where we do have hepatitis B viral load that is elevated and the patient has normal ALT. Okay, yes, absolutely. So actually I do have another case that I want to share. This is a 67-year-old Venezuelan woman. She was recently diagnosed with hepatitis B. She recently immigrated. Obviously, we know about the Venezuelan crisis that's going on. So she came to Miami and she established care in my clinic. She comes with some labs, actually. So she does have hepatitis B surface antigen, and she did have it at least a couple of times in the last 6 months. And this patient was a follow-up for me. I'm seeing her for, I believe, second or third time already. This was last Monday. So we did have some additional information. She is also hepatitis B e antigen negative. Now, We didn't talk about genotypes, but in my clinic, I also check for hepatitis B genotype. She has genotype D. Her hepatitis B DNA is about 3,550. Okay, so as Dr. Alex presented or suggested, this patient has a high viral load. I also check for hepatitis delta. Whenever the viral loads are low, we should think about hepatitis delta, which is a defective virus that coexists with hepatitis B, and she was negative for hepatitis delta. She was immune to hepatitis A. She doesn't have any hepatitis C antibody. She was negative for it. And when we checked her liver function test, her ALT is 13. Her platelets are 361. She denies having any kind of liver-specific symptoms, no ascites, no jaundice, never had any right upper quadrant pain. This was, again, she was told that all her liver tests were normal in the past, and she basically came for what can we do for this patient. She had an ultrasound, and like I said, I knew her for about 6 months. The last ultrasound was sometime in January of 2019, which was normal liver echogenicity. Bile ducts were normal, and it did not show any focal lesions that would raise our concern for HCC. I asked for a FibroScan, and initially, due to language barriers, commuting, and other things, she couldn't get the FibroScan as I wanted, but she just came with a FibroScan. And I want to share that as a kind of suspense, because this is where we can actually discuss more about how to deal with this patient. She was treatment naive all through. She never was exposed to any hepatitis B treatments. Her past medical history was suggestive for osteoporosis. She does have vitamin D deficiency, and she's on the vitamin D supplements. Surgery, she had a breast cyst excision in 1970, 3 cesarean sections, the last one was 1984. She's up to date with her colonoscopy. Medications-wise, she's on nothing except for vitamin D and Boniva for the osteoporosis. Review of systems, only positive for occasional backaches and arthralgias in the knees, but otherwise negative. Physical examination as well, liver and spleen were not palpable. She doesn't have any stigmata of portal hypertension, no spiral angiomata, no icterus, no pulmonary erythema. So again, looking at her labs, I told you before, platelets were 361. Creatinine is normal in this patient, 0.7. If you look at liver function tests, ALT is 13. Total bilirubin is 0.6, albumin is 4.5, INR is 1. Hepatitis B serologies again, just for, because this is a serology module. So she had hepatitis B genotype D. There were no polymerase mutations detected. Remember, she's E antigen negative, but the polymerase mutations were in fact negative. She's immune to hepatitis A. Hepatitis B core antibody is positive. Hepatitis B surface antigen was reactive. Hepatitis B DNA was about 3550. E antigen is negative. Okay, so patient on the first glance, you think that the patient has normal ultrasound, normal platelets, no real concern for treating this patient, and this patient is in fact, and if you classify with the old terminology, she's immunotolerant, right? So whether to treat or not is the big question. Talk to me, Kate.
Dr. Bhamidimarri, I think we had a raised hand from Jane. Jane, you should be unmuted now. Was there something you wanted to share with the group?
Yeah, I would have loved to know what the AST was to have an idea of what the APRI score could turn out to be.
Sure, absolutely. So the AST is 22.
Okay. Okay.
So Alex from Brazil, he said she probably have no fibrosis, and the APRI score is low because the platelets are low, and I mean AST is also low. So for that reason, we can assume that the APRI score will be low. So I too thought that that would be the case, and she will be monitored as a patient with immunotolerance, right? So immunotolerance is basically a situation or a condition where the patient's immunity tolerates a high level of viral load, but the patient's ALT is normal. The age of the patient is 67. So to kind of break the suspense, the patient's fibroscan, this was done in May of 2019, came out to be 19.4 kilopascals, and her CAP score came out to be 242. Okay, so yes, I agree with Dr. Alex that the patient is older than 30 years of age. And although there is a debate about whether to treat or not in immunotolerant individuals, typically we err on the side. We incline towards treating this patient, especially if they're older than 30, especially if they're males, and especially if they're African American, because in those individuals, the risk for HCC is much higher. Okay, but again, if you don't want to treat this patient, this discussion is still debatable just based on a normal fibroscan. But with the fibroscan being 19.4, would you think that the patient has advanced fibrosis and the ALT is probably, remember the ALT can fluctuate. So if you're only checking few times during the course, you may probably getting the troughs of the ALT, and you may not really catching the times when the ALT is peaked, right? So again, being a transplant hepatologist, this fibroscan being high, especially in the range of advanced fibrosis to cirrhosis, this is definitely in the range of F3 to F4 for a hepatitis B patient. So my inclination was to start treatment for this patient, okay? But we'll talk about the fibroscan and other issues in the upcoming slides, okay? So again, I would like to see what the group thinks about this case, if they have any opinions to share, if they want to agree, disagree, discuss more. I think this is a perfect opportunity. Yeah, so again, Alex puts the question in the group, do you really trust this fibroscan? Okay, so yeah, being, we do the fibroscans ourselves in the University of Miami, and we actually look for the IQR range, which is the interquartile variation between the readings. We do about 10 readings. And all 10 of them actually came out to be in the range of advanced fibrosis. So again, the next question is, should you biopsy this patient? So her BMI is also surprisingly, yeah, she's in the overweight range. She's about 28. So yeah, I would biopsy this patient. But again, in my mind, I'm already thinking that given the elevated fibroscan, being an older aged woman, I'm favoring towards treating this patient. Okay, but your points are well taken, Dr. Mora, that yeah, biopsy is our next step, and let's confirm if she really has advanced fibrosis or not. Okay, so let's go on with the presentation. So when we're thinking about how the ALT and hepatitis B DNA behave during a course of chronic hepatitis B, you'll see that ALT levels can be fluctuating. And during these fluctuating courses, if you are doing tests rarely or sporadically, and you may be only testing when the ALT is low, this could be one of the situations like our second patient. So therefore, again, this actually warrants, if you're not treating this patient and if you want to get more data points about whether this patient has elevated ALT, I would recommend testing ALT at least every 3 months, especially if you're not treating this patient. Okay? And again, when you're looking at the DNA levels, the DNA levels can be, at least by definition, she's in the range to undergo treatment. So that is a treatment opportunity there. And she's E antigen negative. So any virus that is more than 2,000 international units should be considered for treatment, especially if she's older than 30 years. So we talked about chronic infection versus chronic hepatitis. Infection means the ALT is normal, and hepatitis means the ALT is high, and that's the newer terminology. Now, if the patient does have cirrhosis or liver cancer or evidence of portal hypertension, you clearly need to treat this patient. So this is kind of a recap of old versus new terminologies combined. So when we talk about chronic hepatitis B infection, if the surface antigen is positive, and if the E antigen is positive, if you look in the first column, the old terminology is this is a patient, especially with normal ALT, this is a patient with immunotolerance. Okay? Typically in these patients, if they're younger, their liver disease doesn't have too much scarring, and these patients can be watched. And like I said, the only scenarios you will think about treatment is if the patient gets older than 30, African-American patient, and a male patient. Those are the ones where you want to treat because the risk of HCC is high. Okay, so these are all the other scenarios where in an immune reactive patient, you see the surface antigen will be positive, DNA will be elevated, and ALT will be elevated. Now, in a patient who is an inactive carrier, you will have hepatitis B viral load typically less than 2,000. ALT will also be normal. And again, in inactive carriers, typically the disease remains kind of stable, and they may not show evidence of significant disease. In E antigen negative chronic hepatitis, you will see again that the ALT is elevated, hepatitis B DNA is elevated, and in this patient, again, this poses an opportunity to treat the individuals. Okay, and in a resolved hepatitis B infection, this is typically if an adult contracts hepatitis B, the patient will have surface antigen initially positive, but eventually the surface antibody will turn positive, and the patient will remain just with hepatitis B core antibody. Okay. So far, any questions? Today it's a quiet group. We need Alex, we need Mubin, we need all the people who are attending, be vocal. At least shoot us whether you agree with the decisions that were made about these cases.
Oh, we've got a raised hand from Jane. Jane, you should be unmuted now.
Okay, I just wanted to find out. You had said if the hepatitis B antigen negative and the viral load is more than 2,000, you still go ahead to treat. Just wanted to clarify that, please.
So for an E antigen negative patient, the recommendations to treat will be if the DNA is more than 2,000 and if the ALT is elevated. Those are the indications to actually treat the patient.
Okay.
Right? So in our patient, her hepatitis B DNA is about 3550, about 3,500, but her ALT is 13. It's normal.
Okay. Okay.
So she is not really in a immune clearance or an immunoactive phase of hepatitis B.
Mhm.
And except for the FibroScan being abnormal, we do not have any indication that her liver disease is actually progressing.
Okay.
Right?
Yeah.
So for that reason, like Dr. Mora suggested, do we trust the FibroScan? Do you think that the FibroScan is real? So again, the confirmatory test for evaluating fibrosis, although you're going to evaluate a smaller piece of the liver, is a biopsy. Add to the data point about us making a decision whether to treat or not. Okay, so again, let's say that the patient does indeed has fatty liver. Okay, her BMI is 28, but she is actually cirrhotic, but by hepatitis B guidelines, she doesn't really fit the criteria for immune reactive hepatitis B. However, the reason that the patient has cirrhosis should actually lower your threshold that this patient should be treated, because any reactivation that can happen in this patient in her later years of life will be very detrimental. Right? Okay. So, Cade?
Yes.
This last slide about interpretation of serologies, the matching schema, will the audience see it or?
Yeah, I believe we removed the animation so that they could see all of it, and then you could address that one by one.
Got it. Okay. So again, to kind of go ahead with the serology issues, the first one is a 52-year-old Korean male, and he has hepatitis B surface antigen positive, E antigen is negative, E antibody is positive, and hepatitis B DNA is negative. Now, in this patient, the patient has normal ALT.
Dr. Bhamidimarri, apologies for the interruption. Were you meaning to share your screen for this portion of it?
Oh, yes.
Perfect. Just wanted to check.
Are you able to see my screen?
Yep, now it's looking good. If you could just go full screen, that would be great.
Yes. So if you guys can all see, the 52-year-old Korean man is similar to our previous case, E antigen negative, but surface antigen is positive. The only key difference is his DNA is undetectable or in low titers, and ALT is normal. Now, this is a patient who does have inactive carrier hepatitis, inactive carrier state, okay? So again, ALT being normal tells us that there is no activity, at least no inflammation within the liver, although this is not a very good test to test for inflammation. And DNA being undetectable or in low titers tells us that the immunity is basically controlling it, okay? So this is an inactive carrier patient. This patient should not be discharged from your practice. You will continue to follow these patients with hepatitis B panel, DNA, LFTs, alpha-fetoprotein, and an ultrasound periodically. He's 52 years of age. So again, his risk for HCC does exist, but although not as high as a patient with very high viral load. And very high viral load meaning 5 logs of viral load. Okay? All we want to make sure is during the process, as he becomes older, we don't want his immunity to kind of give up the control on the hepatitis B, and then the hepatitis B reactivates and causes issues, okay? We want to test every 6 months in order to find an opportunity to treat this patient if he gets any of those risk factors. The second patient is a 38-year-old Vietnamese man. He has hepatitis B surface antigen positive, E antigen is also positive, E antibody is negative, and hepatitis B DNA is elevated. And when we say elevated for a hepatitis B E antigen, we typically mean over 20,000 international units. And this patient also has ALT, which is elevated, meaning if it's a man, it's clearly over 30. And this is a patient who has the clinical phase called chronic hepatitis, or the old terminology is immune active infection. Okay, so in this patient, again, you would favor treating this patient because this is an opportunity where you can actually minimize his risk of progression of liver disease. The next scenario, this is a 25-year-old Nigerian woman. She has hepatitis B surface antigen positive, E antigen is positive, E antibody is negative, hepatitis B DNA is definitely elevated more than 20,000 international units. However, this patient has ALT in the normal range. So this patient is clearly in the immunotolerant phase, okay? As per the new terminology, this will be called chronic infection. And again, need to understand that this patient's immunity is tolerating a high viral load. So again, in her case, we need to figure out whether she has advanced fibrosis or not. We will do a fiber scan or one of the non-invasive tests. It could be APRI score or FIB score. And she's 25 and she's a woman, so she is in the reproductive age range. So we look for other reasons to treat. So we talk about family history, we talk about does anyone in the family has liver cancer, and if any of those are positive, we would again favor treatment in this patient. And if the patient's fibrosis is not significant, then we would continuously watch this patient for HCC and for flares of hepatitis B. So again, we need to test labs and hepatitis B panel every 6 months. The fourth scenario is a 52-year-old Taiwanese woman. Now she has surface antigen, which is negative, surface antibody is negative, and hepatitis B core antibody is positive. Her ALT is normal. Now in this scenario, obviously, you know, this is a patient with isolated core antibody, right? So again, we talked about this in the previous module. Most of the time, the core antibody means the patient has been previously infected with hepatitis B. So we ask for all the history in the past about her exposure to hepatitis B. Remember, she comes from an endemic area of the world. So the chances are she probably was exposed to hepatitis B. So why did she not develop a surface antibody? So again, with age, surface antibody can wane in titer, right? So that is one of the things you need to worry about. And if the surface antibody is negative, you can actually think about giving her a booster for surface with the hepatitis B vaccine and see if she can mount the surface antibody. Right? So again, for the group, the time is about 3:50. We do have a few more minutes to actually talk about any cases you have, or if you want to talk about the cases that we already discussed.